Thank you for that welcome. Let me share my screen. Okay, you guys see my screen?
Yes.
Right. So thank you again for the introduction. As in past years, this lecture is going to be straight from the SCORE curriculum in terms of its outline. So just a reminder, I always like to start, as with past years, that breast cancer is an incredibly rapidly evolving field. So it's really important to remember when you're taking your ABSITE and ultimately your board exams that when you think about standards of care, there's substandard care. You're not picking that choice on the question. There's standard of care, and that is what the ABSITE and your boards are looking for. And then there's state-of-the-art care, which you may see practiced at many of your institutions, but is not what the ABSITE is looking for. So starting off with an example question. 50-year-old female has 2 centimeters of calcifications found on screening mammogram. She has a core biopsy that shows DCIS. What's the appropriate plan for local treatment? Now you can look at this whole list and say, I've seen all of these done at my institution, but remember there is always a best answer. So a lumpectomy and sentinel node followed by whole breast radiation sounds tempting. We know lumpectomy and radiation, maybe that's the choice you're initially looking for. But sentinel lymph node biopsy, not a part of care for DCIS when you're doing a lumpectomy. Now you may say, oh, what if it was in the upper outer quadrant and you were really worried about damaging the draining lymphatics? The question didn't ask that. Don't overthink it. Lumpectomy alone. Again, you might be thinking, well, I've seen that done at my institution. You know, what if they did lumpectomy alone and then had a DCIS oncotype and it was low so we could omit radiation? The question didn't say that either. So don't add things that aren't there. Mastectomy and sentinel lymph node biopsy, sounds good. But then, oh, what about just mastectomy? Well, maybe you've seen that done at my institution. My residents have seen that because I do a mastectomy with mag trace. But this question doesn't say that, does it? It doesn't say mastectomy and mag trace injection. It just says mastectomy. So again, don't read into it. Tamoxifen and close monitoring. Yes, there's multiple ongoing clinical trials, and we have some preliminary results from them. And so some of you may see at your institutions close monitoring of low-grade DCIS. That is not what this question asked. It's asking about local treatment. So your answer is mastectomy and sentinel lymph node biopsy. So starting with our outline anatomy, the breast is made of lobes of milk, lobes of tissue that make milk, and then ducts that carry that milk to the nipple. You can have cancer in either of those, lobular cancer or ductal cancer. Do men have lobes that are making milk? In general, no. So if a question asks you what type of breast cancer are men most likely to get, ductal. Women also most likely to get a ductal cancer. Most epithelial tissue in the breast is located in the upper outer quadrant, so that is the site of most malignant and benign disease. The breast is contained by an envelope of fascia, and then we have Cooper's ligaments that provide structural support. They insert perpendicularly into the dermis, and they can cause skin retraction if you have a breast mass. Down here, we have the inframammary fold or the circummammary ligament formed by the fusion of the superficial fascia, campers, and scarpas. Noting also that these ducts go all the way through to the skin at the nipple. So that is important consideration when you're talking about types of mastectomy, especially nipple-sparing mastectomy. So if you have preoperative evidence of nipple involvement, including Paget's disease, nipple discharge associated with malignancy, imaging findings suggesting malignant involvement of the nipple or subareolar tissues, all of those are contraindications to nipple preservation. You also have to take a dedicated nipple margin as per the NCCN guidelines. And if that comes back positive, the standard of care would be to go back and remove the nipple areola complex. In terms of a mastectomy, the surgical boundaries of the breast are the clavicle superiorly, border of the sternum medially, superior border of the rectus sheath inferiorly, that's that IMF or circummammary ligament, and the edge of the latissimus dorsi laterally. Main blood supply to the breast, internal mammary artery, lateral thoracic artery, and some intercostal artery branches as well. Those are detailed here. You guys have done mastectomies. You've run into these always in the same place. Nerves, very high yield for the ABSITE. Long thoracic nerve innervates serratus anterior. Injury is wing scapula. Thoracodorsal nerve innervates lat dorsi. The injury gives you weak adduction, that pull-up motion. Median pectoral nerve, this wraps around the lateral edge of pec minor and then inserts into pec major, innervating both pec major and pec minor. That is one of the nerves we localize if we're doing local regional blocks, that pec 1 block. It's also really important for reconstruction. If you injure that, they will cause atrophy of those muscles, which can make a difference if you had a subpectoral or even prepectoral implant. The lateral pectoral nerve innervates pec major only. And finally, intercostal brachial nerve provides sensation to the medial underarm and the axilla, and is the most common nerve to be injured in axillary surgery, both a sentinel lymph node biopsy and a axillary dissection. The axilla is defined by the axillary vein superiorly. In questions of relationships, just remember the arteries superior to the vein and the brachial plexus superior to both of those. The latissimus dorsi laterally, serratus anterior medially, subscapularis and teres minor posteriorly, and your clavipectoral fascia overlying the anterior border, as well as the pectoralis muscles as you get into level 2 and 3. Remember, we divide the lymphatics into 3 levels. Level 1, which is lateral to pec minor, level 2 behind pec minor, level 3 medial to pec minor. When thinking about your risk of lymphedema, as quoted by the NSABP trials, with a sentinel lymph node biopsy, that's up to 7%, with an axillary dissection, up to 30%. That's with an axillary dissection alone. But there's other things you can do to increase your risk of lymphedema. Basically messing with any other nodes than you already have. So if you dissect outside the boundaries of the axilla, superior to the axillary vein, for example, you'll increase your risk of lymphedema. If you perform a mastectomy, you'll increase your risk of lymphedema because you have these little internal mammary or intramammary nodes that you're removing that could have picked up some slack for draining that arm. If you have radiation, that increases your risk of lymphedema as it causes fibrosis of the lymph nodes, as does chemotherapy and obesity. Moving on to imaging and biopsies, reminder, screening mammogram, 2 standard views, CC and then MLO, which is tilted just slightly lateral to get that axillary tail of Spence. A screening mammogram is indicated for screening alone. We recommend yearly starting at age 40. That is everybody and proceeding annually. If you have a family history and are high risk, then in general, we start 10 years younger prior to the youngest age of diagnosis in the family, but not prior to age 30. Under age 30, screening mammography is a very low yield due to the extreme density of the breast tissue at that age. When you talk about diagnostic imaging, now you're talking about something that is for evaluation of an abnormality. That could be for breast pain, for an abnormal finding found on prior imaging, follow-up after a biopsy, a palpable mass. We recommend a diagnostic mammogram as the initial mode of diagnostic evaluation for patients who are age 30 or over, again, because under age 30, those patients in general have such dense tissue that the mammogram is not as worthwhile. So if you have a patient who is under 30 presenting with a breast mass, that initial workup would be with a ultrasound. Over 30, diagnostic mammogram. When you order an ultrasound, you can have a limited ultrasound, which again we use for diagnostic workup, or a complete ultrasound, scanning the entire breast, which we use for additional screening for women with dense breast tissue. The third form of breast imaging that you will commonly see in MRI, this can be used as diagnostic workup or for additional screening for patients with a lifetime risk of breast cancer greater than 20%. That is our cutoff for high risk. The reminder, average risk for breast cancer in the female US population, 12%, high risk cutoff 20%. And in general, we don't start screening MRIs prior to age 25. All breast imaging gets a BI-RADS score. This is a high yield and should be an easy question for you to get right. BI-RADS 0, you need additional evaluation immediately. So you have a mammogram, it shows a vague asymmetry. You want to follow it up with a diagnostic mammogram and ultrasound. That's BI-RADS 0. BI-RADS 1, a completely negative study. You don't see anything at all. The follow-up is continuing back to your routine screening, which for women at average risk, age 40 and over, would be an annual mammogram. BI-RADS 2 also completely benign, but there is some sort of finding, like a simple cyst. Same follow-up as BI-RADS 1, return to annual screening if you're over 40. BI-RADS 3 is the turning point. This is a probably benign finding, and we recommend short interval follow-up, which would be with 6-month follow-up imaging. BI-RADS 4 shows a suspicious abnormality, and at a minimum, you should discuss a biopsy. BI-RADS 5, highly suggestive of cancer. Again, biopsy is the next step, and BI-RADS 6 is known a biopsy-proven malignancy. When we're talking about biopsy, the type of biopsy we always prefer is a core needle biopsy. There are very unusual circumstances where there's a location of a tumor or location of a finding that you cannot access with a core biopsy, and then you may need to do a surgical biopsy, but a core biopsy is always preferred. Sometimes you do a core biopsy and you still need to proceed with an excisional biopsy. This could happen if you have inconclusive histology. If pathology can't definitively say this isn't cancer, then you usually need an excisional biopsy to make sure. If there's inadequate sampling, so if you did a stereotactic biopsy for calcifications and there were no calcifications on specimen radiograph, then you should have a surgical biopsy. If there's discordance between imaging and pathology, so if what the pathology shows does not make sense with what your imaging showed, then a biopsy, an excisional biopsy is recommended. And then certain proliferative lesions, a papilloma with atypia, some radial scars that go together with suspicious imaging, a fibroadenoma with complex findings, some atypia, including atypical ductal hyperplasia, columnar cell hyperplasia with atypia, and non-classical LCIS. The reason you're going to surgery for all of these findings is to rule out cancer. These are not precursor lesions. They don't need to be excised with negative margins. The purpose of surgery is to rule out cancer that you just missed with that core biopsy, because we know so many of these findings, when you're talking about these lesions, occur in and around cancers. Moving on to benign disease. There's a lot, and we'll go through it quickly. Mastitis and abscess. The most common cause of those is ductictasia, which we see dilation of those ducts in breastfeeding and in women who smoke. The most common organism is Staph aureus, so your antibiotic selection should be focused around that. You want to keep breastfeeding or pumping, emptying the breast normally for women who are breastfeeding. Again, antibiotics focusing around Staph aureus, Clinda, Bactrim also have the advantage of covering for MRSA. Bactrim should not be taken by mothers nursing newborns or compromised neonates due to the increased risk of kernicterus. If you have mastitis, there's no collection, so there's nothing to drain. But if you have an abscess as well as the antibiotics, you want to do some kind of aspiration or drainage. When you're looking at what kind of drainage you're doing, again, for mastitis, there's nothing to drain. A needle aspiration can be appropriate if the overlying skin is intact. This may require repeat drainages. An incision and drainage is indicated if you have overlying skin that is compromised, like this picture where it's thinned and necrotic, or if you have someone that has failed multiple needle aspirations. In general, if you are treating someone and they're not responding, you think about these two things, antibiotics and drainage. So do you have the appropriate antibiotic coverage? Do you have appropriate source control? Retroareolar abscesses are the hardest to treat. That's shown up on prior exams. They're most likely to recur and require repeat aspirations and sometimes even surgical removal. An abscess that does not resolve is always suspicious, and ultimately a core biopsy might be required to rule out a malignancy. A galactocele, also presenting with a mass in lactation. This is ruptured alveoli containing milk, usually caused by a blocked duct. They present as a painful, tender, palpable lump, but unlike an abscess, there are no systemic findings. There's no fever, there's no erythema. The treatment is to keep breastfeeding or pumping. You can do therapeutic ultrasound. Most of these will resolve on their own, or an ultrasound-guided aspiration can be performed both for diagnostic and therapeutic reasons. The risk of fistula is extremely, extremely low. Gynecomastia is development of breast tissue in men. On exam, this should be smooth, firm, symmetrically distributed beneath the areola. So a concentric increase in the breast tissue. You should not have, an increase in just one quadrant. That would be suspicious. This has a number of different causes. It could be idiopathic from medications. There's a number of different medications as well as recreational drugs like marijuana, hormonal aberrations, cirrhosis, or testicular cancer. You don't strictly need imaging unless you're uncertain of the diagnosis. It's never wrong to get that imaging. You always want these patients to have LFTs to make sure there's not, an evidence of liver failure, as well as a testicular exam to rule out testicular cancer as a cause, but otherwise no treatment that is needed. Mastodynia, breast pain. When we talk about true mastodynia, that's glandular breast pain, which is due to fluctuating hormone levels. Anyone who has mastodynia, we do get imaging as workup, even though mastodynia is rarely caused by cancer. You always need that imaging to document that there's no structural abnormality. In the setting of a normal mammogram, most of these patients can be managed with reassurance without any treatment. If the exam is looking for treatment, again, remembering that we are doing evidence-based therapies, that treatment would be danazol or tamoxifen, which is more commonly used. There's no evidence supporting NSAIDs, vitamin E, vitamin B, evening primrose oil, caffeine elimination. So you might see breast surgeons talk about those in clinic, but for your exam, we're looking at evidence-based therapy, which is danazol or tamoxifen. Bromocriptine, as a reminder, has lost its FDA approval for mastodynia. Mondor's thrombophlebitis, again, needs a diagnostic mammogram. You can be tempted with this question that seems so, typical, and having that palpable cord and pain. You still need imaging, and then after the imaging, the treatment of choice is NSAIDs. Fibrocystic changes is really a catch-all term. It is not specific, but the SCORE curriculum continues to list it, so I will continue to include it. So a whole spectrum of clinical, histologic, and mammographic findings. Sometimes that can be associated with breast pain. On biopsy, you can see adenosis, cysts, apical metaplasia, stromal fibrosis, hyperplasia. None of this is cancer. None of it increases your risk of cancer. None of it becomes cancer. Moving on to cysts. Simple cysts need no intervention. On an ultrasound, that is a completely anechoic circumscribed lesion. It might have this posterior enhancement, this light underneath that. If you cannot say for sure that something is a cyst on ultrasound, we often call that a complex cyst. This can be a collection of cysts, like a cluster of grapes, where you can't say for sure could something solid be hiding in there, or even two cysts that are very close together that share that wall, where again, you couldn't say for certain, could there be a lesion hiding, or a cyst with some debris in the bottom. Again, likely just a cyst, but we can't say for sure, and we're always extremely cautious in the world of breast imaging. So complex cysts, in general, either have short interval follow-up or aspiration. If after aspiration a mass persists, then you do need to move to a core biopsy. Fat necrosis is a finding caused by devascularization of tissue, either from trauma or surgery. On imaging, it shows this classic oil cyst or an eggshell calcification. This is one of the few things you can see on breast imaging or have described to you in a question where you do not need a biopsy because it's completely pathognomonic. Again, that soap bubble egg shape. If you did have a biopsy, you would expect it to show something like lipid-laden macrophages, saponification, or some signs of chronic inflammatory changes. Nothing to do for treatment of fat necrosis. A radial scar, another benign lesion. This is not a scar. It's called a radial scar because it has this scar-like appearance on imaging. It's a sclerosing lesion caused by proliferation of terminal ductules and stromal elements. On mammogram, you see this stellate irregular spiculated mass. That sounds very much like what cancer looks like on a mammogram. So the difference is cancer has a central density, whereas radial scars should have this central lucency. You can see the same thing on ultrasound sometimes where the center appears to be less dense, whereas a cancer, you would expect the center to be the most dense. Either way, you cannot see one of these on imaging and say, yeah, that's just a radial scar. Even if you see that classic central lucency, these always require a biopsy. If the biopsy reveals a radial scar, some of these ultimately require surgical excision and some do not. Radial scars that presented looking like this, we tend to excise. Sometimes though, you biopsy something else and you get a radial scar, and those in general, you do not need to excise. So those small incidental radial scars diagnosed with core biopsy and coordinate imaging findings can just be observed. Moving on to a fibroadenoma. On ultrasound, you will see these as a circumscribed lesion that is usually parallel to the skin, meaning it's wider than it is tall. Usually circumscribed, it can be macromolecular lobulated. Sometimes you see this kind of thin echogenic rim called a pseudocapsule. On mammogram, if you do see these, they're usually a degenerated fibroadenoma, which we call these popcorn lesions. It's these coarse calcifications. If you feel confident that that's what it is, sometimes we can view these on imaging and do no biopsy. If a radiologist is not completely confident, or for lesions that are greater than 2 centimeters on ultrasound, we do tend to biopsy. And the reason we're biopsying is to rule out the second type of fibroepithelial lesion, which is a phylloides tumor. So like a fibroadenoma, this is from proliferation of stroma and mammary epithelium. You see on pathology this whorled stroma that forms these kind of larger clefts lined by epithelium. Some people describe that as leaf-like or frond-like. These phylloides tumors can range from benign to malignant. Like other sarcomas, they have hematogenous metastasis, meaning that you do not need to perform a sentinel lymph node biopsy for treatment or staging. We grade them like other sarcomas with mitoses per high power field. And the treatment, again, wide local excision, no need for sentinel lymph node biopsy or axillary lymph node dissection for treatment or staging. Nipple discharge, when we always want to divide into physiologic or non-physiologic. Physiologic nipple discharge is non-spontaneous, meaning it's elicited and from multiple ducts. Non-physiologic discharge is discharge that is spontaneous from a single duct, and in general, it could be clear or bloody, whereas physiologic, you'd expect it to be milky. The most common cause of bloody nipple discharge is an intraductal papilloma. Workup for a woman with nipple discharge would include a mammogram and ultrasound. If these are negative, you could proceed with an MRI or ductogram or proceed with a central duct excision. Finally, for benign disease, diffuse papillomatosis. These are not true papillomas. These are these hyperelastic epithelium filling individual ducts. On a mammogram, it can be really hard to tell these from cancer, and that's made harder by the fact that usually there's these innumerable lesions and you can't perform 20 core needle biopsies. So in general, you biopsy the largest or most suspicious, and sometimes you do a few biopsies. Unfortunately, these tend to occur in younger women, and they do ultimately have a greatly increased risk for breast cancer as well. So the management can be very tricky. Moving on to our high-risk lesions. When we think about risk, again, we're talking about a specific type of risk. You can't just say risk of 12%. You have to clarify, are we talking about absolute risk, relative risk, individual risk? So a reminder, absolute risk is the chance that a person will develop disease during a given time period, like 5 years or 10 years or the lifetime. And it refers to a general population. It cannot identify risk of a certain individual person or a group of people. For example, lifetime risk, absolute risk of breast cancer in the US female population is 12%, or 1 in 8 women. Relative risk compares the incidence of cancer between 2 groups. So if you think of 2 groups of women, each group has 100 women. Group A has doesn't have a certain risk factor, group B does have a certain risk factor. And if through observation, one woman in group A gets cancer and two women in group B get cancer, that is a 100% increase in relative risk or relative risk of 2. It does not mean that group B's risk is twice the population's absolute risk. You can't combine those statistics that way. Risk factors for breast cancer: age, nulliparity, age at first birth that's later in life, a earlier menarche, later menopause, exogenous hormone use, alcohol consumption, obesity, family history, and certain benign lesions. Looking at those by relative risk, we see that the highest risk comes with our atypical lesions, and then LCIS with a relative risk of 7. It's showing the same thing. So ADH, atypical ductal hyperplasia, is a high-risk lesion. The management, we perform an excisional biopsy to rule out a cancer that we just missed with sampling error because the upgrade rate is high. More importantly, after you do that and rule out a malignancy, you do have to inform patients of their increased risk for cancer and discuss ways to manage that risk. So they may be amenable to additional screening with MRI, and then discuss risk reduction with tamoxifen. Flat epithelial atypia and ALH, these atypia have much lower upgrade rates than atypical ductal hyperplasia. So in general, if imaging is concordant, you can manage these with close follow-up, but you still must discuss that increased lifetime risk and management options. LCIS, this continues to confuse you guys, is not cancer. On the pathology, differentiating this from DCIS, LCIS lacks ECAD adherent expression. It does come with an absolute risk of 1% per year for a lifetime risk of 20 to 25%. When patients who have LCIS on biopsy develop breast cancer, it is more likely to be an invasive ductal cancer, and your risk is increased in both breasts because LCIS is not a precursor lesion. It is just a sign that you are more likely to develop breast cancer overall. Relative risk, again, is 7. So management, classical LCIS does not require surgical excision. Non-classical should have an excisional biopsy, and pleomorphic LCIS is actually considered to be a precursor lesion and should be excised with negative margins. And then for all of those patients, you would discuss tamoxifen for risk reduction. As a reminder, tamoxifen was validated initially with the NSABP P1 trial, a placebo-controlled randomized controlled trial where women with an increased risk of breast cancer were randomized to 5 years of placebo or tamoxifen, and the tamoxifen group had a 50% reduction in risk. Moving on to genetics. The majority of breast cancer is not inherited. Only about 5 to 10% of breast cancer is genetic. Of those inherited cancers, about 50% are due to our BRCA mutations, BRCA1 and 2, but we know today that there are multiple genes associated with inherited risk of breast cancer. Those genes come with different overall lifetime risks, so we stratify them into high risk, moderate risk, and low risk. I'm just going to review the high risk genes today. BRCA1, 2, these are tumor suppressor genes, meaning that they're these gatekeeper and caretaker genes. Their job is to maintain genomic stability. These are loss of function mutations, meaning that this is an autosomal dominant inheritance. Everybody is born with 2 normal copies of these genes. People who have a pathogenic BRCA mutation, in general, they have 1 abnormal copy. And then within those cancer cells, there's a loss of the second copy, and that is how the cancer phenotype develops. Within the Ashkenazi Jewish population, there are 3 specific founder mutations, 2 in BRCA1 and 1 are BRCA2. And those are present in 1 in 40 women within that Ashkenazi Jewish population, whereas in general, the incidence of BRCA1 and 2 populations in the non-Jewish US women population is 1 in 500. That's one of the reasons that Ashkenazi inheritance is something that we always ask about in breast clinic, because within that population, the incidence of these inherited mutations is so much higher. So that is an indication for genetic testing for anyone who has breast cancer and Ashkenazi ancestry, or even just a family history of breast cancer and Ashkenazi ancestry. With the BRCA1 and 2 gene pathogenic mutation, you have an increased risk for breast, ovarian, prostate, colon, melanoma, and pancreatic cancer. When we talk about management, for For the breast, we do higher level of screening. We start MRI at age 25, and at age 30, we add in a mammogram. We also discuss tamoxifen for risk reduction. In terms of the greatest risk reduction, that would be with a prophylactic bilateral mastectomy. That surgery does not reduce risk to zero because there's no mastectomy that removes 100% of breast tissue. From a ovarian cancer standpoint, we do also discuss surveillance. You can do transvaginal public ultrasounds as well as CA-125 blood levels. But these studies, unfortunately, have never proven to decrease the risk of death from ovarian cancer. OCPs do decrease risk of ovarian cancer by over 40%, and these do not significantly increase the risk of breast cancer, so we want these patients on oral contraceptive pills. And then for ovarian cancer, surgery is also an option for a BSO to decrease that risk of ovarian cancer by 80%. Removing the ovaries also the risk of breast cancer by about 50% because you are decreasing the estrogen so significantly. Remember, in some of your institutions, you might see these patients managed with a staging salpingectomy until they're done childbearing. That is state-of-the-art care. That is not standard of care. So your board answer is that BSO. BRCA1 found on chromosome 17. Your female breast cancer lifetime risk 60 to 80%. Male breast cancer lifetime risk 1 to 5%. Ovarian cancer 45%. When you look at these patients with a BRCA1 mutation who develop breast cancer, the most common cancer in these patients is still luminal, but there is an overall higher proportion of triple negative cancers than in the general population. It's one of the reasons that when we look at genetic testing, anyone who has a triple negative breast cancer is recommended to undergo testing, because we know again that within that BRCA population, you are more likely to get a triple negative cancer. That can be really tricky on the exam because, again, if you have a patient who has a BRCA1 mutation and what type of breast cancer are they most likely to get, it's still luminal. It's just that the proportion overall of triple negative cancers is higher than the general population. BRCA is the more common mutation than BRCA1 in the than BRCA2 in the non-Ashkenazi population. BRCA2 is found on chromosome 13. When I was a resident, I remembered that as 1, 2, 3. Female breast cancer risk 60 to 80%. Male breast cancer lifetime risk a little bit higher than with BRCA1, now 5 to 10%. Ovarian cancer lifetime risk 10 to 30. This is more likely to be of luminal subtype than BRCA1. Other high-risk mutations quickly, Lee-Fermoni syndrome, mutation in P53. We used to call this SBLA syndrome, which stood for childhood sarcomas, breast and brain tumors, leukemia, and adrenal cancer. But really, these patients can have almost any type of cancer: GI, renal, lung, thyroid, gonadal, melanoma. Cowden syndrome, from your P10 mutation, we think of breast cancer, thyroid cancer, uterine, kidney, colorectal melanoma. These patients often have macrocephaly and facial trichomonas. Hereditary diffuse gastric cancer is very popular from the GI portion of your exam, but you also remember that the second most common malignancy seen for these patients with that CDH1 mutation is lobular breast cancer, which is why from genetic testing standpoint, our NCCN guidelines say if you have a family history of gastric cancer and lobular breast cancer, that's an indication for testing. Peutz-Jeghers, STK11, these patients typically have those pigmented mucosal lesions and hamartomatous GI polyps, but their lifetime risk of breast cancer is also significantly elevated. And finally, PALB2, I think of this as BRCA junior. These patients have an increased risk of breast, pancreatic, and ovarian cancer. The guidelines for testing continue to evolve, and sounds like you guys are less likely to be asked about them today, but in general, you should refer for genetic counseling, possibly testing if any family member has a known genetic mutation, or if on your pathology you see a mutation in these genes. Sometimes you don't know then, is this something that is inherited or acquired? Anybody with personal history of ovarian, pancreatic, metastatic prostate, colorectal cancer, actually, that has lost its indication. That was only around for about a year. A family history of breast cancer and Ashkenazi ancestry. Also, if you have breast cancer and, again, Ashkenazi ancestry, if you're diagnosed under 50, any triple negative breast cancer, if you have more than one breast cancer primary, and any male breast cancer. In terms of family history if you had breast cancer, and again, it's diagnosed at a young age, or you have breast cancer and a family member who's diagnosed at a young age. If you have a lot of family members with breast cancer, if you have a family history of ovarian cancer or high-grade metastatic prostate cancer, pancreatic cancer, or male breast cancer. And the last point with genetics, remember that in addition to a positive result or a negative result, you can get a variant of uncertain significance. We treat these as benign. The majority ultimately will be reclassified as benign. They do not alter our management. So moving on to cancer. We'll go through intrinsic subtypes and biomarkers, some classic subtypes, and then some rare types, and then discuss surgery. So when we think about the behavior of cancer, we talk about histologic subtypes, intrinsic subtypes, and tumor genomics. All of this is really important for staging, treatment, and prognosis. AJCC 8th edition now does incorporate histologic grade as well as receptors and genomic assays into staging, because we know that ultimately the biology of the cancer is the most important thing, not its size. ER, PR, and HER2, the 3 required receptors that must be tested for in every breast cancer in the US. These are non-genomic biomarkers. They're not associated with any underlying genomic alteration. They are prognostic as well as therapy predictive. The, again, only mandatory biomarkers for breast cancer, and they are incorporated into our current staging. When we think about intrinsic subtypes, we are looking at, is there a way that we can define one type of breast cancer from another? And ultimately, there are likely dozens of types of breast cancer, but in terms of the way we classify patients today, it was really defined by the Carolina Breast Cancer Study, which looked at surgical specimens and characterized them using a complementary DNA microarray representing over 8,000 human genes. And based on that, they were able to define kind of these 4 main subtypes: luminal A, luminal B, HER2 enriched, basal-like, and those distinct subtypes corresponded with patterns of gene expression that were really clustered on these microarrays. Today, we cannot afford to do that for every patient. It is cost prohibitive. So instead of gene expression-based molecular subtypes, we have these clinically defined subtypes, and we use to estimate then the prognosis and guide therapeutic decisions. These subtypes are based on ER, PR, HER2, and sometimes also Ki67 and grade. So luminal A is your most common subtype, strongly ER, PR positive, HER2 negative, in general, a lower Ki67 and lower grade, and that is your best prognosis. Luminal B, still ER, PR positive, but sometimes you see lower levels, like an ER 30% and maybe PR negative. They could have a higher Ki67, be a higher grade, and they have a slightly worse prognosis than luminal A. HER2 enriched cancers are HER2 positive. They have a poor prognosis, although today we have excellent targeted therapies. Basal, like subtype, often corresponds to triple negative breast cancers, also with a poor prognosis. From a therapy standpoint, we know that chemotherapy is necessary for treatment of basal and HER2 enriched subtypes unless they are caught incredibly early with tumor size less than or equal to 5 millimeters, those T1A lesions. When we're treating breast cancer, we talk about local therapies, surgery, and radiation, and then systemic therapies, which include chemotherapy, targeted therapies, immunotherapy, and anti-hormonal therapy. For surgery, there's 2 options for anyone with breast cancer: partial mastectomy, removing the tumor, leaving the breast intact, versus a mastectomy. Those options are equivalent, really important. One is not superior to the other. For invasive cancers, we perform those in conjunction with a sentinel lymph node biopsy, which is done with some tracer, either a single tracer or a dual tracer. Those could be a radioisotope, typically technetium sulfur colloid, or a vital blue dye, which could be isosulfan blue or methylene blue. With those dyes, remember, isosulfan blue does have that 1% incidence of anaphylaxis. Methylene blue, in terms of risks, there's a risk of skin necrosis as well as serotonin syndrome. There are newer tracers available like MagTrace. I don't expect those to show up on your exam, but they could. When you're performing an axillary dissection for breast cancer, we are just removing the level 1 and 2 nodes versus, for example, a melanoma axillary dissection, which would also include level 3. There's some confusion sometimes with what are we talking about with a mastectomy. A mastectomy, in general, either total mastectomy or some people call it a simple mastectomy, you're removing not all breast tissue, but as much breast tissue as possible from that clavicle superiorly to the IMF inferiorly, or the sternum medially, latissimus laterally. A nipple-sparing mastectomy, you're preserving the skin envelope, including the nipple areola complex. A modified radical mastectomy is now that mastectomy and level 1 and 2 nodes. A radical mastectomy is no longer performed. This is just of historical interest that we did remove not only the breast tissue, the overlying skin, but also pec major, pec minor, and the level 1, 2, and 3 nodes. Just one more point on that. Again, there's no mastectomy removes 100% of the breast tissue. So if you see a patient after mastectomy with a palpable mass, they do need a biopsy. In terms of breast conserving surgery, in general, we follow this with radiation, and that is what makes it equivalent to a mastectomy. State-of-the-art care is looking at omission of radiation in some populations, but in general, they go hand in hand. If you think about contraindications to breast conserving therapy, really what we're thinking of are what are the contraindications to radiation. So you cannot give radiation during pregnancy, meaning that if you have someone in the first or second trimester, really you should be looking at a mastectomy. Third trimester, the timing can work out that you still do that surgery, wait until delivery, and then follow with radiation. Patients who have had prior therapeutic radiation to the breast area sometimes cannot have radiation, but depending on the dosage, they can. If you have diffuse microcalcifications spanning enough tissue that it can't be removed without deforming the breast, then you do need a mastectomy as well. Relative contraindications to radiation include scleroderma, lupus, and other collagen vascular diseases. In terms of multifocal multicentric disease, that is not in itself a contraindication. It's really, is there a cosmetically unacceptable result? How much tissue are you removing and how much are you leaving behind? But as long as you can remove all cancer, just purely having multicentric disease is not a contraindication. It's more an idea of breast size versus tumor size. Management of the axilla is increasingly complex. Important to remember, if you do a sentinel lymph node biopsy and it does not map, standard of care is proceeding with an axillary dissection because you don't know were your nodes so consumed by tumor that they were unable to take up any of that mapping dye. Today, for somebody who has an initially node positive disease, and they have preoperative chemotherapy, there is the potential to convert them to node negative and still proceed with a sentinel lymph node biopsy. Remember, side effect of chronic lymphedema as well. Sometimes the radiation is lymphangiosarcoma and an aggressive sarcoma that presents with this kind of purplish red lesion. Moving on to types of breast cancer, DCIS, stage 0 breast cancer. These are malignant cells that are confined by the basement membrane of the duct. We have different subtypes, papillary, that is the best prognosis, all the way to comedo, which is the worst. That comedo shows that central necrosis on pathology. These usually present as mammographic calcifications or less commonly as a mass. And again, we stage them as stage 0 because DCIS by definition should have no potential to spread. If the cancer is confined to the ducts and the ducts are confined to the breast, DCIS should not have any potential to spread to other parts of the body. Treatment is with a partial mastectomy and radiation, where we'd want a 2 mm margin, or a total mastectomy. When you perform a total mastectomy for DCIS, you do a sentinel lymph node biopsy as well. You don't need a sentinel lymph node biopsy for a partial mastectomy or for DCIS in general, again, because it doesn't have that potential to spread. But if you do a partial mastectomy and find invasive cancer, you have the option to go back and repeat a sentinel lymph node biopsy. If you do a total mastectomy and you find invasive cancer, you lose the opportunity to go back for a sentinel lymph node because you have nothing left to map. So that is the reason that if you do a mastectomy, you should perform a sentinel lymph node biopsy. It's in case you find invasive cancer, where with a total mastectomy, you've lost that ability to perform a delayed sentinel lymph node biopsy. And then for patients who are ER positive, we also discuss anti-hormonal therapy for 5 years. Moving on to invasive cancers, invasive ductal cancer represents over 85% of breast cancer, the most common. Invasive lobular cancer is about 10% of breast cancer. It does have a tendency, more so than ductal, to be bilateral or multifocal or even multicentric. It is usually a luminal biology and can be underrepresented on mammogram. These lobular cancers don't grow like a mass like most adenocarcinomas. They tend to grow sending out kind of individual spindules and in sheets, almost like a spider web. So these are often underrepresented on imaging. Less common subtypes, which are favorable: tubular, mucinous, papillary, medullary, tubulo-lobular, and adenocystic, all very favorable prognosis. Unfavorable subtypes: micropapillary and metaplastic, those both with a metaplastic, very poor prognosis. Micropapillary is aggressive with a high rate of lymph node metastasis. Paget's disease is DCIS of the nipple. It's very rare. You see nipple erythema and crusting and kind of a scaling ulcerated lesion. My residents always say, "Oh, do you have a picture you can share for us?" No, it doesn't really photograph well. This is a really subtle finding. Paget's really whispers at you. It does not shout at you. But anybody who has these suspicious nipple changes, especially if they're unilateral, should have a biopsy of the nipple, which you would expect to show those Paget cell, that in situ carcinoma. 95% of patients with Paget's disease do have an underlying breast cancer, so it's important to get imaging to rule out an invasive cancer somewhere else in the breast. And if there's no additional lesions, you can proceed with a central lumpectomy, removing that nipple areal complex, or a mastectomy, which at that point you would perform with that sentinel lymph node biopsy. Inflammatory breast cancer typically presents with that inflamed, tender breast, erythema, and that poda-orange edema of the breast, or it looks like an orange peel. On punch biopsy, you see dermal lymphatic invasion, but this is a clinical diagnosis. You don't need that punch biopsy to confirm it. Treatment: neoadjuvant chemotherapy, then a modified radical mastectomy, and followed by radiation. When you're performing that modified radical mastectomy, it should be a true mastectomy, not a skin-sparing mastectomy, for 2 reasons. One, you have such a high risk of recurrence. You're really trying to remove as much skin as possible, and skin-sparing mastectomy has not been demonstrated to be safe. We also don't perform immediate reconstruction, 1, because we're trying to remove as much skin as possible, but 2, because we would not want to have any kind of difficulty with reconstruction that could delay moving on to your next line of adjuvant therapy, because these cancers are so aggressive. Male breast cancers can be associated with BRCA mutations, especially BRCA2, Klinefelter syndrome. They are almost all ductal. The majority are luminal. The therapy in general, we extrapolate from treatment of the female population, meaning they can have breast conservation and a sentinel node biopsy, and we can treat them afterwards with tamoxifen or an AI, which is given in combination with a GnRH analog. Gestational breast cancer, the big thing is that you don't want to delay diagnosis or treatment. If you see a woman who is pregnant or lactating with a breast mass, you never want to assume it's just pregnancy or lactational changes. You want to get imaging and biopsy if indicated. We always think about radiation with pregnancy, so you could do a lumpectomy in the 3rd trimester and radiate after delivery, but not in the 1st or 2nd. We don't give chemo in the 1st trimester, but in general, it's safe in the 2nd and 3rd. We don't give Herceptin or methotrexate during pregnancy. These patients can have sentinel lymph node biopsy, but not with a vital blue dye, because that will cross the placental membrane. And immediate reconstruction is a little bit of an area of controversy, whether we do that or not. Years ago, we said no. Today, it's likely safe. You're just thinking about this time under general anesthesia, which in general is probably not that increased when you're doing immediate reconstruction. In terms of neoadjuvant and adjuvant therapies in our last 10 minutes, neoadjuvant and adjuvant therapy, again, can include chemotherapy, targeted therapy like endocrine therapy or HER2-based therapy, immunotherapy, and then radiation. Chemotherapy occasionally can be asked on the ABSITE in terms of specific chemotherapy agents and their risks. I used to, every year before the ABSITE, kind of draw out and refresh in my mind that chemotox man that a lot of us learned in med school, to remember some of the classic side effects. You should look up and review that. Endocrine therapy, there's 3 types of endocrine therapy. Only 2 are first line, your SERMs and your AIs. SERMs, your selective estrogen receptor modulators, tamoxifen and raloxifene. In the breast, they are competitive antagonists, but they have agonistic functions elsewhere, which is why there's a slight increased risk of endometrial cancer. The other risk to be concerned about is embolism. They are metabolized by that CYTP450 enzyme. I put the little broccoli there to remind you in case there's questions on that. AIs and anastrozole, letrozole, exemestane, their mechanism of action is blocking conversion of androgens to estrogens by aromatase. These can only be used in women who are postmenopausal or women who don't have functional ovaries, or in combination with ovarian suppression. If you give them alone in someone who has functioning ovaries, the effect is minimal because you have the ovaries just pumping out estrogen. So decreasing, peripheral production really does nothing. One of the bigger concerns is osteoporosis because you are decreasing overall estrogen levels. Fulvestrant, that is a pure ER antagonist, that is only a second-line treatment. And in general, we prescribe that treatment for 5 to 10 years. Other targeted therapies, all of our HER2 new targeted therapies, tyrosine kinase inhibitors, PARP inhibitors, in general are only indicated for germline BRCA mutations. CDK4/6 inhibitors are used today for patients who have more aggressive ER-positive cancers. Immunotherapy, currently we are only using for high-risk triple-negative disease. That is that pembrolizumab. So who should have chemotherapy? For luminal cancers, the majority of these do not require chemotherapy, but if they are greater or equal to 5 millimeters or they're involving lymph nodes, usually we use a genomic assay like an oncotype to help determine the need and benefit of chemotherapy. HER2 positive therapy should really be considered for all patients with HER2 positive disease. For triple negative cancers, again, if it's your T1b or greater or you have nodal involvement. Tubular, mucinous, and papillary cancers, in case you do see these are so favorable that if they're ER positive and node negative, they do not need chemotherapy, and you do not need to request any genomic assay to validate that. In terms of when we give chemotherapy, before or after surgery, there are some advantages to giving chemotherapy before surgery. One, it can shrink your tumor size, helping to make surgery easier, maybe converting someone who would have required a mastectomy or an axillary dissection to breast conservation and a sentinel lymph node biopsy. But even more importantly, it does give us really helpful information on the tumor response, which can then help you tailor treatment on the back end. So in general, if we know someone's going to require chemotherapy, we do like giving it beforehand for those reasons. Radiation, I'm going to skip through because it seems to have been downplayed more recently in the ABSITE, but just remembering that, that is really when you're doing a breast conserving surgery, what is making that equivalent to a mastectomy. Some people have a mastectomy and still require radiation, especially tumors that are greater than 5 centimeters or have very close margins, less than a millimeter, or for patients that have positive lymph nodes. Finally, reconstruction. When we think about reconstruction with a mastectomy, it is the standard of care to offer patients reconstruction. By law, insurance also must cover reconstruction. We can do that either in immediate or delayed fashion, meaning doing that reconstruction at the time of surgery or later on down the road. It can also be one-step reconstruction or staged reconstruction, where you start the reconstruction with your surgery, maybe with a tissue expander, and then do additional procedures down the line. There's 2 main ways to reconstruct the breast: implant-based reconstruction, saline or silicone, and autologous reconstruction. When you're looking at who should get what, the major consideration is really radiation. And if you have a radiated plane, it is or if you are planning for radiation, it's best to place a tissue expander and do a final reconstruction afterwards so that you're not radiating your final reconstruction. If your patient has already had radiation, like someone who had breast conserving therapy and radiation, and now they have a recurrence, the best option for reconstruction is autologous because radiation really changes that tissue forever. The healing is always going to be impaired, so putting a foreign body in can be very difficult. The most common cause of flap ischemia is venous thrombosis. It's not arterial clotting. And the only true contraindication to a deep or tram flap, which is our most common site of tissue procurement for autologous reconstruction, is prior abdominoplasty. And that is that end of whirlwind breast, and I'm happy to take any questions. Let's see anything in the chat. There's one Q&A. When is sentinel lymph node indicated in DCIS? So again, DCIS by definition should not have the ability to spread outside the breast because if the cancer is confined to the ducts, and we know the ducts are confined to the breast, then it should not have that potential. So if you are doing a lumpectomy for DCIS, you don't need a sentinel lymph node biopsy. The only reason we consider sentinel lymph node biopsy is because sometimes we get DCIS on a core biopsy, but there's invasive cancer that we missed. If you're performing a mastectomy for DCIS and you find invasive cancer, you can't go back and perform a sentinel lymph node biopsy because there's no tissue to inject your mapping dye into. So the standard of care, if you're performing a mastectomy for DCIS, is to perform a sentinel lymph node biopsy. In state-of-the-art care, we can now inject magtrace, which remains in the lymph nodes for months, allowing that delayed sentinel lymph node biopsy. I'd be surprised if that came up on your exam, but that is also a viable option. Question 2, can you talk a little bit more about timing for reconstruction and absolute contraindications for immediate reconstruction besides radiation? So radiation isn't a contraindication to immediate reconstruction. If you know someone will need radiation, we're just more likely to perform a staged reconstruction, meaning at the time of surgery, we're still going to put in some breast mound, but usually a tissue expander. It's still helpful to start that reconstruction because you're preserving the skin envelope, whereas if you're not putting in a tissue expander, you have to take more skin and then later on down the road after radiation expand that skin. So you do get a better cosmetic result, but we don't want to radiate the final implant or the final autologous reconstruction if we can help it. For somebody with inflammatory breast cancer, that is a contraindication to immediate reconstruction, again, because it's not validated to perform a skin-sparing mastectomy. And also, we don't want to delay them moving on to their next line of therapy. And immediate reconstruction always comes with that slight risk of infection or flap necrosis leading to delays in treatment. Pregnancy used to be a contraindication to immediate reconstruction, but that really is no longer something that's universally held true. So I don't think you would see that question on your exam.